Hi, everyone. We're going to go ahead and get started. Thanks for coming to our grand rounds. My name is Bindi. I'm one of the chief residents, and I have the privilege of announcing our speakers today. Our first speaker is Dr. Marcela Ferrada. Dr. Ferrada earned her medical degree at the Universidad de Valle in Cali, Colombia. She completed her internal medicine residency here at the University of Miami Jackson Memorial Hospital and spent 1 year as chief resident. She also completed a dual fellowship in critical care medicine at the National Institutes of Health and infectious diseases at Johns Hopkins. In 2015, she was diagnosed with relapsing polychondritis, a rare inflammatory rheumatologic disorder. After her diagnosis, she changed her career focus to study this disease and completed a rheumatology fellowship at the NIH's National Institute of Arthritis and Musculoskeletal and Skin Diseases. Dr. Ferrada is board certified in internal medicine, critical care, infectious diseases, and rheumatology. She is a member of the Alpha Omega Alpha Honor Medical Society and the recipient of several awards. This is including the Distinguished Fellow Award from the American College of Rheumatology, the Outstanding Research Award from the Rheumatism Society of the District of Columbia, and the Lawrence Shulman Scholar Award in 2019, and the NIH Directors Award in 2021. Dr. Ferrada was pivotal in recruiting and evaluating patients on the first prospective cohort of patients with relapsing polychondritis at the NIH. She has become a world leader in the field and is currently director of the Relapsing Polychondritis and VEXAS program at the University of Maryland. Please welcome Dr. Ferrada.
Okay, this is, oh my gosh, what a pleasure to be here and then see familiar faces. I feel at home, and I'm very, very proud to be here today. Thank you so much for giving me the opportunity. I just want to disclose that all my images are ChatGPT made. Okay, so at the beginning of any, different life as a physicians, we always see ourselves as being having that, right? Having a specific tower that looks just like that. But unfortunately, that is not what happens in life. And I was one of those. I was like, this is exactly what I'm going to do. But no, I mean, the things happen in life. And to me, what basically exploded my crystal ball, because all the thing that we have a crystal ball, was the diagnosis of relapsing polychondritis. And then this is me the first time that I was admitted to the ICU with two of my best friends. And then when you get diagnosed with a disease that is a rare disease, it is not a rare disease anymore. It's to you, to your family, 100%. And then this was me at the beginning. So I think the slides are just like PDF, but I will work through it. But then this was me trying to find, help. Like, what is it that you're going to do after you finish 2 fellowships, right? And you're ready to start being an attending, and then you're giving the diagnosis of relapsing polychondritis, and what are you going to do with that? It was definitely very difficult for me to transition from being a physician to be a patient, as it would be for anybody of us, because we're physicians and we are a little bit controlling. So taking the role of a patient is extremely challenging. I decided to use that challenge to rebuild my crystal ball, and with a lot of help, obviously, because you always, I'm just going to use this, sorry. Yeah, so I always, you need to have, of course, a lot of help. I mean, if you think about all of us, you're not here just you, right? I mean, you're here because your parents, your friends, your mentors. And then I think that is always very important to look for help to be able to achieve what you want to do. And at the end of the day, always end up being
a team effort, right? When you are successful, like the way that I feel right now, like all the people that I see, like, you were part of my team. I mean, like, you were my medical student. So amazing. So, and then, and again, I use that with a lot of help and to rebuild my crystal ball by using the experience as a patient combined with the knowledge and experience as a physician. And I believe that that gave me superpowers, because then you have a different perspective that it really, really helps you to be a good physician. And I thought I was compassionate, but after you have to experience the other side of the coin, you realize that not that much. So what is relapsing polychondritis? Relapsing polychondritis is a rare inflammatory disease that is systemic, that has a predilection for cartilage. However, this disease is extremely heterogeneous, and that is what I learned when I first started studying this disease, that all the patients nobody respond to the same treatment, although that is common in rheumatology, but the patients were just very different. And because of that, when I was doing my rheumatology fellowship at NIH, we decided to study this disease and try to identify specific subgroups that were more homogeneous, and that way you were able to study apples with apples. And to be able to do that, when I was at NIH, we used something called the phenotype approach, which means I was collating a lot of data clinically, because I'm a clinician, I have clinician superpowers. So I was collecting all of that, and we also had a lot of blood tests, and particularly trying to identify any test that will help us find organ damage early. And with that, what I did was a type of study called latent class analysis, and identify using prospective data, because this was the first prospective cohort of patients with relapsing polychondritis that ever exist. And I identified 3 different subtypes. This figure I love very much because the drawing was made by one of my patients. That is an artist. It looks like a little alien, but I think that is beautiful. And then, so just to orient you here, the darker the color, the higher the percentage of organ involvement. And for this particular study, what I decided to do was utilize variables that were very objective. So it is late disease because it is organ damage, right? So the red ear, the nose that is super, super dark, and the airway, those signified damage, right? So type 1 are the patients that have cauliflower ears, saddle nose deformity, subglottic stenosis, tracheomalacia. Type 2 are patients that have mainly lower airway disease. So these patients are characterized by having tracheomalacia, and the type 3 are all the other ones. So again, this is just to emphasize that the patients that have the type 1 are the less common type of relapsing polychondritis. However, this is what we learn in medical school, right? With somebody, if ever remember relapsing polychondritis, then it would be like, oh, the patient has a cauliflower ear and the saddle. Those are the smallest group of patients. So, and I think this is very important, because it is the typical RP, but it's the less common, right? So it should not be called the typical one. And those are the patients that have significant damage very quickly. Type 2 are the patients that have lower airway disease. These patients you can recognize them as a patient that has adult onset asthma or very difficult to treat asthma. And when you ask them about other symptoms, and you find that they have sacroiliitis, episodes of arthritis, and then you do a dynamic CT scan and they have bronchomalacia. And the type 3, which is the one that is more heterogeneous, which is the most common one, are patients that have a pattern of organ involvement that will give the patients the diagnosis of relapsing polychondritis. Because at this point, the way that you diagnose relapsing polychondritis is based in clinical symptoms. And this diagnosis criteria was generated in the 1960s by a doctor called McAdams, but unfortunately has not been validated, and is basically in recognizing the pattern of organ involvement, which include nose chondritis, ear chondritis, airway chondritis, non-erosive arthritis, eye inflammation, and inner ear disease. However, we do not have a definition of this organ involvement, but we're working on it. So these patients meet criteria for relapsing polychondritis because they have usually ear redness, nose redness, sometimes they can have respiratory symptoms, but at the same time, I found that they have many other manifestations that have not been described in the literature before. And in this group is where VEXAS was, where we found VEXAS, and also a condition like a syndrome called MAGIC syndrome, which is basically Behçet's, mouth and genital ulcers with inflamed cartilage. The person that put the title MAGIC, he was telling me, he works at UCSD, he was telling me, oh no, we just did that because we were having some beer and then we thought that MAGIC was catchy. Yeah, not MAGIC, okay? So then, and what I have learned, but this is still a hypothesis that I have to prove, is that some of these patients may have mitochondrial dysfunction, which is what is leading to these different symptoms. And we always had the suspicion that ear chondritis was associated with a hematologic malignancies, right? It's like in the LTC, if you have ear chondritis, you always have to think about myelodysplastic syndrome. This is very funny, I mean, to me, because when I was learning about this, I was like, no, that is not true, because these patients have, you know, methotrexate, cyclophosphamide. This is not a correlation. Well, there is a correlation, and these are the patients that have VEXAS. So like me, other researchers have been trying to subgroup patients with relapsing polychondritis to be able to identify homogeneous populations. And the first group that did this is Dion and collaborators. This is a very large study done in France. It was a retrospective study of 146 patients, and they did a cluster analysis. And what is interesting is that they identified the hematologic subgroup. And to me, that is the first clinical description of VEXAS, right? So if you take a look at the cluster of hematologic abnormalities, then you see these patients had thrombosis, they have general symptoms, they die more. Basically, a patient with VEXAS described clinically. But then after we discover, or David discovered the mutation that we know, I believe that this subgroup is likely explained due to VEXAS. So David Beck is a geneticist, he's currently at NYU, and he had a particular interest in the ubiquitin pathway, and he studied a lot of exons that were available at NIH, and he utilized 3 different parameters to identify like rare variables, and found 3 patients that had a somatic mutation in the same location of that gene, which is position M41. This is the other mutations are all in exon 3. And then just for everybody to know, well, it is not new anymore because this was done in 2020, but VEXAS is a relatively new genetically defined disease that is due to somatic mutations acquired in the UBA1 gene in bone marrow stem cells. And these patients have an overlap of inflammatory manifestations with hematologic abnormalities. It's very interesting. And then, unfortunately, the disease is at the moment, because I think that over time we will be able to overcome that, is refractory and is often fatal. But I believe that the reason that that is the case right now is because we're discovering the disease late. And this is the VEXAS monster. I also did it with AI. I should make like t-shirts. It's actually kind of cool. But so what is VEXAS mean? Is because these patients have vacuoles in the bone marrow. That is one of the like very distinct characteristics of this disease. E is because the mutations lead to the decrease of the E1 enzyme, which is the first enzyme that starts the ubiquitin pathway. And I am going to show you in a very, I think that fun way to remember. And I'm going to explain why this is important, because I know we're all clinicians. I mean, I remember when I was a fellow, right? And then you have somebody talking about genes and things, and you're like, okay, I just ate lunch. But I explained to you in a way that you remember, and I explained to you why this is important. And X is because it's X-linked. A, because of the autoinflammatory manifestation, and S, because the mutations are somatic. And this is what the way that I'm going to explain to you. So yes, I'm a clinician, so the first time that they were talking to me about genes, and I was like, I just don't remember, that was a long time ago. And then, so this is the way that I figured out how to understand it very, very easily. So the E1 enzyme is basically the enzyme that is in charge of producing ubiquitin. And why ubiquitin is important? Because ubiquitin is what is used to tag all the proteins that need to be removed. That is the ubiquitin process, the pathway. That is what is the reason that you have it inside your cells. So the proteins that are unwanted can be removed. Now, what happens if you don't have the E1 enzyme? So then you don't have ubiquitin tickets, and all the unwanted proteins cannot go to gel. And the problem is that all these unwanted proteins are likely the source of the inflammatory process. And the reason that I'm saying that is because we were able to study these in some of the patients, and we proved that the variants of the mutations that were associated with less production of ubiquitin were the patients that have more inflammation. So that is what I think that it is fascinating. And then in here, this is just a very simple a cartoon showing what happened with the mutation, right? So if you don't have any mutations in the position M41, you're going to be able to produce ubiquitin, right? So this is the UBA1. And if you have these mutations, then you're not going to be able to produce UBA1. And that is why you have inflammation. That is one of the theories. So we have gone from have the suspicion that ear chondritis is associated with a hematologic malignancy to have an understanding of how this is due to a genetic mutation. And this is because I had a relationship with the ear, right? So at the beginning of this disease, I was always very upset that, of course, I have my own biases, that many patients were not diagnosed until they have ear chondritis. And that's a problem. And the problem is because there are patients that have airway disease that will have ear chondritis 13 years after they have airway disease. So if you're going to be waiting for the ear, you may be able to, like, you probably are missing a lot of inflammation that can lead to organ damage. So every time that I saw a case of a patient that, you know, the disease was missed, the diagnosis because of the ear, so I was always very, very mad, and I was like, no. And all my talks, the title was like, relapsing polychondritis more than a swollen ear. This is not the ear. The ear is not important, but the ear, it is important because it was actually the ear what it helped me make the connection. So on the right side is Peter Grayson, and this side is David Beck, and I was working with Peter Grayson at NIH. And one day he came to lab meeting and he said, oh, you know, I think that we discovered a new disease. And I was like, oh, this is so cool. And then he said, you know, and it's so weird because, you know, these three patients had some kind of like ear chondritis. And I was like, what? So then I talked to David, and he let me review all the charts of the patients. And then I found the clinical features of patients that I have seen in our cohort that sometimes they didn't really make sense to me. And I was like, you need to test these patients. And they all came back with the mutation for VEXAS. So now I really like the ear, and I have spent a lot of time learning about the ear because now I think that is very important because it's what people looked at. So we have to know about ears. And I'm sure that you all guys look at the ears on your patients in every single clinic, right? With an otoscope and everything. So these are the clinical manifestations in VEXAS. Patients with VEXAS have a lot of skin involvement is due to small vessel vasculitis. And so this is the VEXAS main, as you could see, is obviously very systemic, no? And the symptoms and the clinical features are really associated with the type of mutation that you have, as I was saying before. So if you have the mutation that the change on the methionine is to valine, that means that the patient is going to have less ubiquitin and more inflammation. And that's important because I believe that those are the patients that should be treated more aggressively in terms of advanced therapies. And because at that time, we just didn't know how to identify these patients better, we developed an algorithm, and we found that if you have a male patient with ear and nose chondritis, and this patient have an elevated MCV or a little bit of thrombocytopenia, you're going to be very likely to find a mutation in the UA1 causing VEXAS in that patient. This has changed a lot because since the first description, we have found that patients with the UA mutation that leads to pathology can have a tremendous different type of clinical manifestations. So if you see a patient that is having elevated inflammatory markers and you cannot really put it in a particular box of a diagnosis, you should consider a diagnosis of VEXAS. I mean, we saw these patients with diagnosis of relapsing polychondritis, but at the same time, they have neutrophilic dermatitis, and at the same time, they have polyarteritis nodosa. So when all of that is mixed then, and also patients that have ANCA-associated vasculitis and rheumatoid arthritis. So I think that any patient that has an inflammatory process that is not quite like the other patients, and the patient has an elevated MCV, you should consider testing for VEXAS. So we also went and evaluated patients that have VEXAS with RP and those that didn't have the mutation, and then we found, of course, that they were very different. And patients with VEXAS were older, they were males, they have more skin lesions. And I'm highlighting airway disease because that was one of the things that I initially found that it was very distinct, that patients with RP without VEXAS had airway disease, and the patients that had VEXAS did not have airway disease. But the Japanese group found a few patients that had tracheal thickening, but not malacia. So that still could be part of their symptomatology. Okay, so how many people here likes to drink beer? You guys are very brave. Yes, yeah, you're really, yeah. So, yeah, and then what is it that I'm talking about beer here? Actually, beer was the Egyptians used to feed beer to their kids because it's very nutritious. I am not advocating anybody to drink beer, okay? So, and the reason that I'm talking about this is because this is the first case of relapsing polychondritis that was available in the literature. So you could see here, kind of, saddle nose and a cauliflower ear. So my husband, he speaks German, and in an act of love, he translated this article for me overnight, so I was able to read it. And this was a 34-year-old male that had epiglottitis and joint swellings and all of that, and all of the other symptoms that were inflammatory. And the author of this case concluded that the patient had this disease because he happened to be a brewer and he was drinking 8 liters of beer per day. We have not, I think that is probably because he was having so much pain. So we have not been able to I mean, there may be a correlation, but we have not been able to find a correlation between beer and relapsing polychondritis. So don't drink 8 liters, but I think that I don't think you will have RP. So we have been going from thinking that beer is the cause of relapsing polychondritis to finding different subgroups, to develop clinical classification based on prospective data to find 8% of the cause of relapsing polychondritis, which is genetic. And then I think that is, to me, is fascinating. I mean, I'm very, very thankful, grateful to everybody that has helped me during my career, including, this was the first time that I mean, here is where I had the wonderful opportunity to train in internal medicine. It was amazing, and I think that it was the support, and help that I had since the beginning that really encouraged me to move forward with what I wanted to do in my career. And I think that this is to show you that it doesn't matter what you decide to do. If you do it with passion and because you really care, you're going to achieve whatever you want to do. And this is my definition of hope. And it is that the belief that the future will be better because we have the power to make it happen. And these are patients in the RP group, because I saw a patient that was hospitalized, very sick, but she posted a picture like this. And I was like, well, that's very powerful. And I am putting these, and I usually put these in my presentations because I want to remind you all that you are the hope for the patients. And don't forget that. Okay, you just need to sit with your patient for 5 minutes. And once the patient feel that they have somebody that really care, just that is hope. And so that is to show what sometimes the way that I see the management of these patients is, because it's like you don't know what to do. I think that I am the one that has the eye like this, like crooked. And what I'm hoping is that with time, and hopefully if we are able to continue doing research, that we're going to have the capability to have a better plan and more organized to help patients have a better life. And then this is the group of physicians that I really, really want to thank for their help when I was first diagnosed, and of course, our patients. So I will be happy to, and right now I'm at the University of Maryland. I'm very happy I'm given the opportunity to be there, and I will be happy to answer any questions. Thank you for listening.
Thank you, Dr. Ferrada, for that very entertaining and informative talk. We have time for just a few questions. Maybe I can begin by, as much as I appreciate the rheumatologist's physical exam and history and the litany of serologic tests that they can obtain, seem almost endless. Where do you put the role of genetic testing early on in when you are presented with a patient with a condition such as this, given the fact that the cost is no longer a prohibitive factor?
Right. So I think that any patient that you suspect, particularly for VEXAS, I mean, in rheumatology, there are many areas where you could consider doing early testing, genetic testing. So any patient that has an ongoing inflammation, you should suspect an autoinflammatory disease, and there is many diseases that can be diagnosed genetically, particularly for VEXAS. If you have an adult patient, it doesn't matter if it's a female or a male, and your patient have inflammatory markers that are elevated, and again, clinical symptoms that are not particularly specific for a condition, and an elevated MCV, you should send the test for VEXAS. And the reason is because this is going to change the management, and it will help you improve the outcome.
Thank you. Well, welcome back to the University of Miami. We're glad you're here. And we'll now begin with the introduction of our next speaker.
So I'd like to introduce our next speaker. We have Dr. Violet Lagari, who is the Associate Professor of Clinical Medicine in the Division of Endocrinology and Diabetes and Metabolism at the University of Miami. She serves as Program Director for the Endocrinology Fellowship and is Section Chief of Endocrinology at the Miami VA Healthcare System. Dr. Lagari has numerous publications in the field of endocrinology with a specific interest in metabolic bone disorders and has a designated bone clinic. She has given annual lectures on bone-related topics to the University of Miami medical students as part of their endocrinology lecture series, and she has directed the bone curriculum for the Endocrinology Fellowship Program for the last decade, which includes both bone lecture series and training in DEXA interpretation. She has been involved in quality improvement initiatives at the Miami VA to prevent fractures through the establishment of a comprehensive program that monitors all bone density scans for patients with a diagnosis of osteoporosis to ensure appropriate evaluation and treatment. She also has been involved at the National VA Work Group to enhance osteoporosis awareness and fracture prevention. Additionally, at the University of Miami, she has improved the process of ordering bone densities for patients with high risks for fracture through EPIC and has been involved in establishing a database of patients with rare bone diseases, of which preliminary results were presented at the most recent Endocrine Society meeting. Please welcome Dr. Lagari.
Hey everyone, I'm so excited to be here. Thank you for having me. So today we're going to talk about Denosumab discontinuation in the clinic. And the objectives for today, we're going to talk about the risks associated with Denosumab discontinuation, how to manage this in the clinic, and then we're going to touch on osteonecrosis of the jaw and how to handle that in patients who are on denosumab. So we're going to start with a case. This is a case that I saw just a few weeks ago that was referred to me by several of you here. A 79-year-old man who came for a second opinion of osteoporosis management. He was diagnosed with osteoporosis on routine bone density, treated with alendronate for about 5 years, and then transitioned to denosumab for 7 years until he needed a tooth extraction. He went to see his dental provider who told him he needed to be off of the denosumab for 4 months before he could have that dental extraction, and then be off of denosumab for an additional 4 months before after that dental extraction. So the patient went off of the denosumab, and 3 months after the last dose wore off, he sustained 3 thoracic compression fractures and had kyphoplasty. He saw an endocrinologist in the community who put him on abaloparatide for 2 years and then performed a bone density. At the end of the 2 years, that bone density showed declines at all sites, with most of the decline happening at the hip. So he came to me to discuss why this had happened and what to do next. So first, let's talk about what is denosumab. So denosumab is a fully human monoclonal antibody to rank ligand that mimics the endogenous action of osteoprogesterone and neutralizes rank ligand completely. And it very, very effectively and efficiently suppresses bone turnover. So osteoclast differentiation and bone turnover. And this is sustained throughout the effects of therapy. The problem with denosumab is as soon as the medication wears off, you have this very severe and intense rebound bone loss that in some cases can be followed by a vertebral fracture. And this is going to be the focus of the talk today. So denosumab is incredibly effective. So it has been shown to decrease fracture risk of all major sites. It has been shown to increase bone mineral density. We don't exactly understand why that is, because it works primarily by affecting the osteoclast, but you do see the sustained increase in bone mineral density. And it has been shown to be very effective across multiple clinical indications. So not just osteoporosis in men and women, but in other clinical settings as well. And what happens with denosumab over time is initially, when you have a patient who starts on denosumab, you get a very profound decrease in the serum CTX. C-telopeptide is a marker in the serum that we use as a surrogate for osteoclast activity. And it's a byproduct of osteoclast degradation. And so when you're on an osteoclast inhibitor, such as denosumab or a bisphosphonate, you would expect that serum CTX levels are going to go down. And so that's what happens with denosumab very, very profoundly. So that decrease, that decline in CTX is sustained throughout the course of therapy. There is a parallel increase in the bone mineral density that occurs on treatment. And the risk of vertebral fracture goes down a lot while patients are on therapy. When denosumab is stopped abruptly and there's no transition to anything else, what happens is you get a very precipitous increase in serum CTX levels that you see here. And this phenomenon here particularly is known as CTX overshoot. And that is the period of time in which you get this very profound increased bone turnover that is mirrored by a very sharp decline in bone mineral density at all sites, and in some cases, a very profound increase in vertebral fracture risk. And we're going to talk about who is at risk for having a vertebral fracture. This is data from the initial FREEDOM trial, looking at patients who are on denosumab for 2 years. And what you see is that in patients who stopped denosumab in both the lumbar spine and total hip, there were precipitous declines in bone mineral density at both sites. This was mirrored by an increase in serum CTX levels, as you see here, consistent with this idea of the increased bone turnover that happens in that CTX overshoot. So this is a post hoc analysis of the FREEDOM trial that evaluated patients during therapy. So the red The red boxes indicate patients who are on, were during the trial period that patients were either randomized to denosumab or placebo. And you see a very significant decline in the risk of vertebral fractures, single and multiple vertebral fractures. And when patients were taken off of the medication, you see this increase, and focusing specifically on the denosumab group, you saw an increase in the risk and the development of vertebral fractures, both single vertebral fractures and multiple vertebral fractures. So who are the patients that are at risk for having vertebral fractures? The most significant risk for developing fractures after discontinuation of denosumab is having a prior history of vertebral fracture. Beyond that, there's two very significant risk factors. One is length of duration of therapy. So patients who are on, so the longer you're on therapy, if you stop denosumab abruptly, this places you at higher risk for having a fracture. And the other one, interestingly, is greater gains in bone mineral density. So those patients who had the largest gains in BMD over the time period that they were on denosumab, when they were taken off, those were the ones that were most at risk for having vertebral fractures. This study basically looked at the interval of time. When is it that patients are at risk for developing those fractures? So essentially, this is an observational study that determined that the patients who are most at risk for developing vertebral fracture, the time frame is 6 months after the last dose of denosumab, and the period between 6 months post last dose of denosumab and 18 months. So essentially, almost a 2-year time frame, not quite 2 years, but almost a 2-year time frame in which the patients are at high risk for developing those vertebral fractures. This is the first study that looked at strategies to try to mitigate the bone loss that you have after denosumab discontinuation. So here, basically, patients were on denosumab for 7 years, so that's a long time. Remember that denosumab is an FDA-approved medication. It's approved for up to 10 years. So in this study, patients were on it for 7 years and given a dose of zoledronic acid at the end of the 7 years of treatment. And what you see is a decline in bone density at both the spine and the total hip. That study was the inspiration for the Zolermab study, which is the only study that we have available to us that is a randomized clinical trial assessing the effect, the best strategy for mitigation of rebound bone loss using zoledronic acid. And the study design is a little bit complicated, but I'm going to kind of summarize the major points so that we can take away what's valuable. So it was a relatively small study of 61 postmenopausal women who had been on denosumab for more than 2 years. And importantly, it excluded patients who had a history of vertebral fractures. They were randomized to one of 3 designs. So the observation group, the 9-month group, and the 6-month group. For our purposes today, I want everyone to focus on the 6-month group because that's what's most clinically relevant to what we're going to be, discussing a little bit later on. The patients who received their last dose of denosumab 6 months after, so essentially when the medication was wearing off, they received a dose of zoledronic acid. That's in the 6-month group right here. The other groups received zoledronic acid a little bit later on. So the patients were monitored with serum CTX levels and bone mineral densities. And then if they had serum CTX levels that were above 1,000, which I think is a little bit too high, but that's what they chose, they were given another dose of zoledronic acid. Or if the bone density had declines of 5% or greater at the major sites, they were given another dose of zoledronic acid. So they were then followed for up to 2 years afterwards. This is the sort of the scheme of how the study went, how many doses of zoledronic acid were given in all of the groups. But just remember that the 6-month group, they got that dose of zoledronic acid right when that last dose of denosumab was wearing off. And what you see here, so focusing on the blue line, so in patients who got that dose of zoledronic acid at the end of the period, so when the denosumab was wearing off, what you see is a decline in bone density in the lumbar spine that eventually sort of tapers off. That's a little bit more gradual. You don't see it as precipitous as the other groups, suggesting that giving a dose of zoledronic acid right away is more effective than waiting, but obviously you're still going to have declines in bone density. Similarly, for hip BMD, you see the declines in bone mineral density that occurred in the group of patients that received that initial dose of zoledronic acid at that right when the treatment ended. That was a little bit more gradual than the other two groups. And this was paralleled with changes in CTX. So in the blue group, so the patients who got that initial dose of zoledronic acid right when the denosumab was wearing off, what you see is that the CTX levels start to climb back up, but you don't see the overshoot like you do with the other groups. So the take-home points from this study are that it's very important to consider a dose of zoledronic acid or at least a bisphosphonate right at the end of therapy, right when that last dose of denosumab is wearing off. And what else can we glean from this study? So basically, the other sort of interesting findings were that in patients who are on denosumab for more than 5 years on average had baseline CTX levels that were higher than patients who are on denosumab for less than 5 years. So again, so what does this tell us? So that basically correlated with those patients who had baseline CTX levels that were higher because they were on therapy for longer with denosumab, had greater declines in bone density overall relative to the patients who are on denosumab for less than 5 years. So again, going for this idea that it's very important to know how long your patients are on denosumab and what is the, to be able to predict how at risk they are for bone loss, vertebral fractures, and to act accordingly. This is another study looking at giving a dose of zoledronic acid at the end of therapy with denosumab in patients who were on denosumab for anywhere between 2 and 5 years. And what you see here, this was an observational study, so there were a lot of limitations with this study, but essentially giving a dose of zoledronic acid at the end of treatment resulted in some bone loss at the spine and total hip. And the other interesting finding is when they stratified patients according to when they had their bone densities done, so interval time between bone density assessments. Those patients that had a bone density done at the start of their the mitigation strategy, so giving them a dose of zoledronic acid, and 1 year later, that group showed the greatest decline in bone density, again, suggesting that the period of time in which denosumab has the greatest bone loss effect is in the year after therapy cessation. What about other medications? So not just zoledronic acid. So this is the DAP study looking at transition from denosumab to alendronate. So oral alendronate, you know, something that's very commonly used in clinics. So how effective is that? So the interesting thing about this study, if we focus just on this group here, looking at the transition from denosumab to alendronate, these were patients that were on alendronate, on denosumab for 1 year and then transitioned to alendronate. And what you found is that in patients who received just 1 year of denosumab and you transition them to alendronate, there wasn't much change in that bone mineral density, suggesting that alendronate is a good option if you have patients on denosumab for a short period of time. So specifically in this case, that was 1 year. This is another study looking at the effect of transitioning patients from denosumab after 2 years to zoledronic acid. And what you see here, just consistent with what we already know, is that in patients who receive that dose of zoledronic acid at the end of treatments, this results in some stabilization of the CTX, the serum CTX, with some loss of bone, but back to baseline. So not too not too severe, the bone loss that happens. They end up having their bone densities go back to what their baseline was, but at least you don't see this precipitous decline that you do with when patients are on their therapy for longer. So this is a summary of all of the studies that I talked about. Some I did and some I didn't. But the main take-home point being that if you look here, according to years of denosumab therapy, in patients who are transitioned to either alendronate, in the case of the DAP study that we talked about, or zoledronic acid, the greatest bone loss occurs in those patients who have been on denosumab for longer. So again, giving credence to this idea that length of therapy is very important. What about teriparatide? So remember that with our case, our patient, he was transitioned from denosumab to teriparatide after having sustained those vertebral fractures. Does that make sense in this in that case? So the only data that we have for transitioning patients from denosumab to teriparatide comes from the data switch study. I'm going to have everyone focus on the red line. So the red line is the patients that were on denosumab therapy in gray and then transitioned to teriparatide. So at all sites, lumbar spine, distal radius, femoral neck, and total hip, if you focus on the red line, what you see is in the patients who are on denosumab and then transition to teriparatide right here, you see a decline in the bone density. Eventually, they can overcome that decline if they stay on the medication for long enough in the spine. But in the distal radius, you see a precipitous decline that never recovers. And similarly, in the femoral neck, at least for the first year of therapy on teriparatide, you see a precipitous decline in bone density in both the femoral neck and the total hip, suggesting that this is just not a good option for transitioning patients. What about romosozumab? So romosozumab is the newest osteoporosis medication that we have available. And there is some new data suggesting that transitioning patients from denosumab to romosozumab can be good. So focusing on this group here, group 2, so this is the lumbar spine and the total hip. These are patients that were on placebo, received denosumab, followed by romosozumab. So they were on denosumab for 2 years, followed by 1 year of romosozumab. And what you see is increases in bone density at the lumbar spine and a little bit at the total hip with stabilization and then a slight increase in bone density, suggesting that romosozumab is a promising medication to use as a transition off of denosumab. This is not part of any formal recommendations or guidelines at this point, but it is there. There are also, other issues with romosozumab that I'm not going to get into now, but we could talk about it another time. This is paralleled by the changes in serum CTX and P1NP. So here is, focusing on group 2, the P1NP, remember, is a marker of bone formation. So, and the CTX, which is a marker of bone resorption. So in both cases in patients who are on denosumab, you see declines in both markers of bone turnover, followed by increases in the group that was transitioned to romosozumab without that overshoot. So it sort of goes back to baseline. So just to mention, why does the rebound bone loss happen? So what are some of the theories behind it? So what we know about why rebound bone loss happens is based on mice models of postmenopausal osteoporosis. So the thought is that there is so much suppression of rank ligand that there's a pooled amount of osteoclast precursors that when you take away that stimulus, there's a rapid differentiation process that occurs, and like this sort of like burst of osteoclastic activity that results in that rebound bone loss. So what can we do for our patients in the clinic? And what did I do for my patient particularly? So the first and most important point, and this is a point that I always emphasize with our fellows in clinic, is patient selection. You have to really determine who is a good candidate for denosumab. If you have a patient who's not compliant, if you have a patient who is at risk for losing insurance, these are not patients that really should be going on denosumab. Beyond that, if you have a patient who is high risk, who would benefit from this medication, and you start them on it, know how long they've been on therapy and know what your treatment goals are. So identify these things early on and talk to your patient about what the treatment goal is. Is it getting their bone density into the osteopenia range? So remember that length of therapy will determine that rebound bone loss effect, and also whether they're at risk for having vertebral fractures. So if you have a patient who is on denosumab for less than 5 years, you can consider oral alendronate. If you have a patient who's on denosumab for more than 5 years, really you should be looking at IV zoledronic acid as your mitigation strategy. The other very, very important point is thinking ahead. So when you have a patient and you're looking to see if they're a good candidate for denosumab, think about whether they're a good candidate for IV zoledronic acid, because if they're not, this may not be a good patient to put on denosumab in the first place. So in the patients that you place on any one of these medications, you really need to monitor the serum CTX. What I do in clinic is I monitor the levels every 3 months, and depending on what the value is, so the literature says anything above the postmenopausal average, which that is never helpful to me, but basically you're looking, I think, for a level above 500 to think about giving another dose of zoledronic acid, and you're going to give multiple sequential doses in that first year after therapy. For patients who have a history of vertebral fractures, you really need to be very aggressive with that mitigation strategy, meaning don't bother with alendronate, put them on IV zoledronic acid, and be very consistent with checking that CTX and using maybe even like a lower threshold for giving another dose to prevent it. Another fracture. This is another summary slide that I liked because it has this nice little traffic light thing, but essentially making the same points. The last slide that I want to just mention is with regard to dental procedures during anti-resorptive therapy, and specifically denosumab. So I've made the point very clear that you can't stop denosumab cold turkey. So what do you do with patients who are faced with a dental provider that wants to do a procedure but is threatening that they won't do it unless you stop medication? There are guidelines that were developed by the American Dental Association, the American Association of Maxillofacial Surgeons. This is a statement from one of the European societies, basically suggesting that if you have a patient who is low risk for ONJ, which is essentially all of our patients that we treat for osteoporosis. So it's basically low risk is an osteoporosis patient. High risk is a cancer patient that's getting doses that are much higher, potentially shorter intervals. And it's just a different protocol that is used by oncology for cancer patients. But anyone that's being treated with denosumab for osteoporosis is essentially extremely low risk for ONJ. Those patients should not be taken off of denosumab. Sometimes it's very difficult to sort of convey this to your dental provider. So what you do is, in order to sort of get around this issue, is have them try to convince them to do the procedure at month 5 to 6 into that dose of denosumab. Presumably because that is sort of like the time when the medication could potentially be wearing off a little bit, and so it sort of gives you that sort of cushion. And if you have a situation in which a dental provider is not conceding and is really giving you a hard time, then it becomes a lot more complicated, and that's a discussion for another time. But that has happened to me, and there are some things that you can do. So to conclude, Denosumab is a very, very good medication. It's super effective while patients are on it. It's FDA approved for 10 years. But we know that if you discontinue the medication abruptly, it can result in increased bone resorption, bone loss, and risk of vertebral fractures. So sequential treatment with IV zoledronic acid can prevent that vertebral fracture from happening, but there will be bone loss. So you must be very clear with your patients that this will happen so that they're prepared psychologically for the bone loss that's going to happen. If you have a patient on therapy for less than 5 years, you can consider oral alendronate. More than 5 years, it really should be IV zoledronic acid, and the risk of ONJ is low, and don't discontinue the denosumab. Thank you.
Dr. Lagari, that was excellent. Thank you for those pearls and management tips. I think this is really important to appreciate the fact that the clinical trials upon which we base our clinical activities on these take years and years to develop, and to be able to present this in terms of where it is now was very good. Your patient, however, was a male. And the data that you presented to us in these trials are postmenopausal osteoporotic women. So how much can we assume that a male patient with osteoporosis, we don't know whether there was a cause of the osteoporosis in this patient, I'm sure you evaluated that would have maybe reflected differently the type of therapy that you would have given after the denosumab was stopped, or consider other treatments at the time. So how do you factor in the male factor?
So thank you for the question. That's a whole topic unto itself. So the pathophysiology of male osteoporosis is a little bit different, but for all pharmaceutical agents, the indication for therapy always starts in osteoporosis with the postmenopausal woman. And so that's where the FDA approval starts. And then years after is when the male approval comes. But for the most part, I would say that all therapies, are effective in male patients as they are to female patients. And in particular, as it pertains to denosumab, there is an indication for male osteoporosis. So it might have been okay.
So let me just ask one quick question more. So if you have a patient who is elderly, been on Prolia for a long time, got to go off it, but the creatinine clearance is not sufficient for giving, reclassed or anything like that, and they're older, so you're worried about a stroke or an MI from giving Denosumab, what options do you have?
So that's the patient that should not have been started on denosumab in the first place. That's my first comment. Yeah, that's the first comment. But the second comment is there's a small body of data for use of raloxifene in these patients that can mitigate some of the bone loss, but it does not prevent vertebral fractures. So that's what I do.
Great. Dr. Mendel, last question.
The New England Journal of Medicine and JAMA are full of articles on the value of physical exercise. And they even go as far to say it's the most effective single therapeutic agent we have. What do you think is the role of physical activity for osteoporosis here?
So that's another great question, which I think that exercise is the end all be all. Like I think that incorporating all components of a very strong physical activity regimen that includes weight bearing, non-weight bearing, stretching, everything is very important for healthy aging. The problem is that it's not enough in some cases. So what happens is with postmenopausal women and in older men, it's very difficult to put on bone mass. So you're not really going to get that very effectively from exercise, especially like weight bearing. That's kind of the what you'll hear a lot of. So the role of medications is very important, and that's what I try to convey in our patients.
Thank you to both our speakers today. Excellent grand rounds. I want to remind everybody that next week is a holiday and we won't be having grand rounds, but we will resume in 2 weeks. Remember to check the QR code on exiting or in the chat and get your CME and MOC credits. Thank you, everybody, for participating today.